This presentation will cover two common respiratory conditions, asthma and allergic rhinitis, and Bethany Von Hoff and I will be your presenter today. For both conditions, we will discuss common causes and symptoms, how the conditions are classified, and how to treat them. To get us on the same page throughout this presentation, I want to briefly cover some definitions so we're using common terminology. Please review this slide for the common terminology, but I will particularly highlight that we will be focusing on asthma in this presentation, but I have included the definition of COPD for your information and for completeness, but they are two different diseases. We will begin by discussing asthma. Asthma is incredibly common. Many of you in this course may have asthma or know someone who does. But because it is so common, many people stop thinking about it as a serious medical condition, but it is. Uncontrolled asthma can interrupt a person's life and can also be fatal. These interruptions can lead to missed work and school and more doctor's visits and hospitalizations. There are more than 5,000 deaths every year from asthma, and many of these deaths are from people who have what is considered mild asthma. Even for someone with mild asthma, a single exacerbation can lead to death. There has been a rise in the incidence of asthma, and the cause is not fully known. It could be from better reporting and tracking, but it also could be from environmental causes. There is a genetic component that makes a patient more at risk for asthma, but there are also other causes or risk factors, including exposure to tobacco smoke, allergies, and obesity. Symptoms of asthma include coughing, wheezing, shortness of breath, or rapid breath from trying to take in more air. There is an overlap of symptoms between asthma and allergic rhinitis. Also, asthma can be triggered by an allergen that can also cause allergic rhinitis. As we discussed earlier, the complications of uncontrolled asthma can be very serious. This picture on the right is of a lung from someone who died from an asthma exacerbation. You can see that there is trapped air and inflammation of the lung. It is very important that asthma is adequately controlled. Asthma is classified based on the severity and frequency of the symptoms as well as when the symptoms occur. For example, a patient who has nighttime awakenings from asthma is a different classification than only having symptoms in the daytime. As the frequency and severity of symptoms increases, then the severity of asthma classification increases as well. The goals of controlling asthma are to prevent symptoms and exacerbations, to limit exposure to allergens, and to allow the patient to live an uninterrupted life with usual activities of daily living. There are a lot of therapy options for the treatment of asthma, and when they are used appropriately, they can do a good job of maintaining health and quality of life for many patients. We will now dive deeper into some of these medication options. Bronchodilators are the mainstay medication for asthma. They work by dilating the bronchial tubes of the lungs, and by making the tubes bigger, air can flow more easily through the lungs. There are short-acting and long-acting bronchodilators. Every patient with asthma should have a short-acting bronchodilator, such as albuterol. This is what is useful in an asthma attack or asthma exacerbation. This provides acute symptom relief. There are also long-acting bronchodilators, but these are usually saved for a last resort because there is potential for danger with their use. These medications are inhaled and act primarily directly on the lungs, so they are usually well tolerated. Some of these side effects are possible, such as rapid heart rate or headache, but usually this is minimized because most of the medication gets to the lungs, which is the site of action. As a reminder, all patients with asthma should have a short-acting inhaler, and the long-acting bronchodilators, when used alone, have been shown to increase the rate of severe asthma attacks. The next class of medications is inhaled steroids. These are very important medications because all patients with asthma have some degree of inflammation in their lungs, even when they have no symptoms. We cannot completely eliminate the inflammation in the lungs, but these inhaled steroids help control and reduce the inflammation. An example of an inhaled steroid is Flovent or fluticasone. Again, these medications have limited side effects because they are inhaled and they act more locally. You can sort of think of it like a topical application of medications, but to the lungs. One common side effect from inhaled steroids is an oral yeast infection, also known as oral thrush. However, this can be easily avoided by rinsing the mouth or brushing the teeth after use. It is important to know that inhaled steroids have no role in an acute attack. They will not be effective in an asthma exacerbation. Their role is in prevention. They have to be taken every day to keep inflammation at its lowest state. Patients often may not feel different after taking the inhaled steroid and may stop taking it and only rely on the short-acting bronchodilators. It is very important to counsel patients on the importance of taking the inhaled steroids regularly because this medication is responsible for keeping inflammation at its lowest state, which will help reduce the number of asthma exacerbations. There are also inhalers that provide a combination of medications, such as an inhaled steroid in combination with a long-acting bronchodilator. Again, these combination products are only for prevention and are not effective in providing acute symptom relief during an asthma exacerbation. The next class of medications is the leukotriene receptor antagonists. This medication is usually used in combination with inhaled medications and is often used in patients who have both asthma and allergies. It blocks a minor step in the inflammatory process, so it's not as effective as other agents. An example of this kind of medication is Singulair. We will switch gears now to talk about allergic rhinitis. You'll find many similarities between allergic rhinitis and asthma. Again, allergic rhinitis is very common, but it is important that the patients get adequate therapy so they can continue to get through their day without complications and troublesome symptoms. There also has been an increase in prevalence of allergic rhinitis, and the cause again is unknown, but may be environmental. There is also a genetic predisposition to allergic rhinitis, as well as common triggers such as tobacco smoke. Also, patients who have asthma or who are diagnosed with the skin condition eczema appear to be at a greater risk of allergic rhinitis. The key symptom of allergies is itching of any kind. In allergic rhinitis, you're specifically looking at itching in the eyes and nose. You're also looking at sneezing, nasal drainage, and there might be a headache due to sinus pressure. Allergic rhinitis can also trigger an asthma attack. There are two different classifications of allergic rhinitis. One is seasonal allergic rhinitis, also known as hay fever, and this is caused by allergens that are only present seasonally in certain times of the year. Then there is also perennial allergic rhinitis, and this is a more consistent rhinitis that shows little variation in the symptoms all year long. The main goals of therapy are to prevent or minimize symptoms, and this is usually through limiting exposure. Most patients can determine their trigger, which helps to limit the exposure. However, even with limiting exposure to the allergen or trigger, medications may be needed to help control symptoms to allow patients to live a normal life. The three main treatment options for allergic rhinitis include antihistamines, decongestants, and nasal steroids. An allergic response is associated with the release of histamine, so we try to block the histamine from getting to the receptors as a way to treat the symptoms of an allergic reaction. These receptors can be found in the brain and in the body. Older medications such as Benadryl were less selective and targeted receptors in the brain and the body, and the targeting of receptors in the brain leads to the sedating effects that Benadryl has. Newer agents such as Zyrtec are more selective and therefore are non-sedating. Both are available over the counter. Antihistamines cause anticholinergic adverse events. So thinking back to the basic pharmacology lecture, anticholinergic side effects include dry mouth, blurry vision, urinary retention. And for some patients, these may be more problematic symptoms, so antihistamines should be avoided in these patients, especially the elderly. This is an acronym to help you remember the anticholinergic side effects. Additionally, there are other potential side effects such as increased heart rate and decreased heat tolerance. The next class of medications are the decongestants, which are used to shrink the nasal membranes. These can be taken orally, such as Sudafed, or used as a spray nasally, such as oxymetazoline. We worry about using decongestants in patients with high blood pressure or cardiovascular disease because it can increase blood pressure and cause changes in heart rate. An important counseling point with the nasal decongestants is that if they are used for more than 3 days in a row, they can cause rebound congestion. This basically means that the patient will feel like the congestion is not going away or is actually getting worse, which may make them want to keep using the spray, which is causing that rebound congestion. Therefore, the patient should never use these sprays for more than 3 days in a row. As we talked about in the drug regulation presentation, pseudoephedrine falls into the behind-the-counter medication category. This is because the medication can be abused and used to make methamphetamine. So pharmacies must track who is buying pseudoephedrine and how much they are buying. There are daily and monthly quantity limits. It can sometimes be confusing to figure out what really is Sudafed. You may see Sudafed on the shelf and think to yourself that you had to buy it behind the counter, and you would be right. But Sudafed is the company name which they put on different medications. So the Sudafed that's on the shelves contains a different decongestant called phenylephrine, which is why you'll often see it labeled as Sudafed PE. Anything that contains true pseudoephedrine, though, will be behind the counter. Just as we talked about inhaled steroids reducing inflammation and asthma, there are also intranasal steroids that work for allergic rhinitis. These work very well, acting locally to decrease inflammation in the nose. Two common examples are Flonase and Nasonex. Nasal steroids used to be available by prescription only, but now some are moving to be available over the counter. So again, with both asthma and allergic rhinitis, we want to use preventative strategies as much as we can to reduce the exposure to triggers and allergens. The goal is to maintain a high quality of life for the patients. Both conditions have agents available for acute therapy. For both conditions, we want to figure out what causes an attack and try to limit exposure to those allergens or triggers, whatever they may be. In summary, both asthma and allergic rhinitis are very common conditions with serious consequences. Some people may be more predisposed to developing them than others. The goals of therapy are to prevent future attacks, make sure the patient is living a high quality of life, and to limit exposure to triggers.